Xin chào tất cả các bạn. Thì hôm trước chúng ta đã tìm hiểu về đặc điểm, hình ảnh Empire City, triệu chứng và chẩn đoán trong thư vùng hào. Hôm nay chúng ta sẽ đến với phần thứ hai, đó chính là phân loại giai đoạn khối u trong thư vùng hào dựa trên City Empire. Ok, chúng ta cùng bắt đầu nhé.
Coming to the staging, T1 disease. So we need to know what is T1. Tumors which is involving tumors confined to nasopharynx that was earlier considered as T1 alone. Now, a tumors involving oropharynx or nasal cavity, it is T1. In most situations in head and neck, we know that the staging is based on the size criteria. In oral cavity, less than 2 centimeter is T1. Less than or equal to 2 to 4, it is T2. Whereas in nasopharynx, it is not based on the size criteria. It is based on the other sites involvement. If you have a glottic tumor extending into supraglottis, it is T2. Whereas in nasopharynx, going into oropharynx, it is still T1. If you have a tumor in base of tongue extending into supraglottic larynx, is T4. Whereas a nasopharynx extending in nasal cavity is T1. So that is T1. I will show few examples of T1. Yeah, I am again coming to this picture. That's a sagittal view. In this, you can see that the tumor extending into the oropharynx or tumor extending into nasal cavity. It is T1. It is a T1 disease. This is a diagnosis of exclusion because in an MRI, you can clearly make out. See, this is the prevertebral muscles. All the planes with the prevertebral muscles are intact. And you make out, and the parapharyngeal space is also intact. That is why it is a T1 disease. The prevertebral muscles are not involved. The parapharyngeal space is not involved. The pterygoid muscles are intact. So it is a T1 disease. Again, I will show this is a soft tissue enhancement. You can make out in the right lateral pharyngeal recess. A small tumor confined to nasopharynx. That's a T1 disease. And even if you can, in this, you can make out the tumor is infiltrating into the posterior aspect of the nasal cavity, and it is still a T1 disease. Now, coming to the T2 disease, in T2, in the 7th TNM, it was in 7th and 8th, it is slight different. So I will discuss what is the update. This is 7th. You can see that the tumors involving the parapharyngeal space or the carotid sheath. So this is the parapharyngeal space is considered as T2 disease. The prevertebral muscle was not included in the stage, and the pterygoid muscles was considered as T4. When they analyzed the data, it was found that the tumors involving medial pterygoid and lateral pterygoid, they have a good prognosis, and they should be subclassified as T2 because the survival curves were similar to T2 disease, and they have restaged the pterygoid muscle involvement as T2 disease, and they have added the prevertebral muscle. Now the T2 is 3 factors. 1, the prevertebral muscles, carotid sheath, then that constitute part of the parapharyngeal space. This is the parapharyngeal space, the carotid sheath and parapharyngeal space. Then the medial and lateral pterygoid muscle. For any tumor which spreads beyond the lateral border of the lateral pterygoid, I told you in the beginning, it becomes a T4 disease. So medial pterygoid and lateral pterygoid is only T2 and it is not T4. The prevertebral muscles, we have to be very clear because prevertebral muscles in T2 in nasopharynx is T2. The prevertebral muscle involvement in larynx and hypopharynx is T4B. Prevertebral muscle involvement is not included in the staging of oropharynx. So the examiner can ask you if the oropharyngeal, the prevertebral muscle is involvement is there, what is the stage? You have to say that it is not involved in the staging of oropharynx. It is from a nasopharyngeal tumor, prevertebral muscles are involved. It is a T2. Whereas in the lower down, in larynx and hypopharynx, prevertebral muscle involvement, it becomes T4 disease. Now coming to, that is the difference between the 7th and the 8th. I will show you examples for each. Suppose you have, this is a typical MRI shows it's a T2. This, can you make out the prevertebral muscle? This is the prevertebral muscle involved. Here on this side, on right side, it is intact. Whereas the prevertebral muscle is infiltrated by the tumor. The parapharyngeal space is involved. The medial pterygoid muscle is involved. So all the 3 factors, prevertebral muscle involvement, the parapharyngeal space, and medial pterygoid involvement is there. This is T2 disease. Now, coming to the next, this is again The parapharyngeal space is involved, and the prevertebral muscle is also involved. It is a T2 disease. And I want to discuss this CT scan also. This is also a classic T2. This is how it will look a normal right parapharyngeal space. Sorry, this is the right parapharyngeal space. This is the right parapharyngeal space. This is the opening of the eustachian tube, the torus tubaris. Posterior to the torus tubaris, you have the lateral pharyngeal recess, the right lateral pharyngeal recess. On left side, it is obliterated. It's replaced by the tumor, and it is infiltrating the prevertebral muscles. Also, the obliteration of the parapharyngeal space, and also involvement of the pterygoid muscle. And you up to the pterygoid plates, the medial pterygoid seems to be infiltrated and very closely affecting the lateral pterygoid muscle also. So this is a T2 disease, and it is not T4. How to contour these tumors will be discussed tomorrow. So muscle involvement in all head and neck sites, like if you have an oral cavity disease, if muscle is involved, say C3 involvement from an oral cavity, tubercle complex tumor, this is a T4 disease. Whereas medial pterygoid and lateral pterygoid muscle, it is only T2 in carcinoma nasopharynx. Now coming to the bony involvement. T3 nasopharynx means classical involvement of bony involvement. Whenever you have a bony involvement, like a skull base involvement, clivus destruction, pterygoid plate destruction, if you have a pterygoid plates are destroyed, or extension into maxilla, phenoid sinus. So bone involvement, this is the clivus. This was a nasopharyngeal carcinoma. Actually, this was patient presented with meningitis. It's one of my patient treated in 2013. And this patient presented with meningitis, and due to clivus destruction and this workup, pylon workup, then from the hospital it was diagnosed after when he was undergoing treatment for meningitis. And this patient was done a CT scan. Then it was the clivus destruction was identified. Biopsy showed undifferentiated carcinoma and referred to us. So this is a T3 disease because a clivus destruction is present. And if you have a C1 destruction, sometimes C1 destruction can occur. It is also a T3 disease. The base of skull involvement, it becomes a base of skull involvement is there. It becomes a T3 disease. You have base of skull involvement, and you have the sphenoid sinus involvement. This is the sphenoid sinus involvement. This is a pterygopalatine fossa. This is a pterygopalatine fossa. Okay, I will discuss that. That is very important for contouring pterygopalatine fossa. Then coming to we need to know the foramina, because when a base of skull is involved, it becomes T3, but when the cranial nerve is involved, it becomes T4. So which are the foramina? This is the optic canal, which shows the optic nerve and the ophthalmic artery. This is a superior orbital fissure. The structures which pass through the superior orbital transmitt are the 3, 4, 6 cranial nerves, the oculomotor, trochlea, abducens, and the first division of the fifth cranial nerve, that is the ophthalmic nerve. This is a superior orbital fissure. This is the foramen rotunda, which transmits the maxillary nerve. The foramen ovale transmits the mandibular nerve, which is the third division of fifth cranial nerve. And this is the lacerum, foramen lacerum. You have the foramen spinosum. I will show you how to read that in a CT scan in the later slides. So the foramen lacerum is the most weak. This is the weakest part of the base of skull. It gain access and spread anteriorly, and it gain access to the cavernous sinus. Then this is the groove for the carotid artery, and on this side, this is the groove for the carotid artery. So I will show if you take a cut at the level of the cavernous sinus, the structures which are involved are 3, 4, 6 cranial nerves and the first and the second division of the fifth cranial nerve. This is the foramen rotunda and foramen ovale. If a cavernous sinus is involved, most probably the mandibular nerve will be spared, but the maxillary nerve will be involved. I will show you that. So this is 3, 4, 6 cranial nerve. The first division enters into the superior orbital fissure. Then this we have seen here. The second division occurs into the foramen rotunda, and third division occurs to the foramen ovale. So the third division will be spared in the cavernous sinus involvement. This is the carotid artery. 3, 4, 6, first and second division of the fifth cranial nerve. And the V3, the mandibular nerve, which is through the foramen ovale, will be spared in a cavernous sinus involvement. Now coming to the other foramina, why it is important to know, because the jugular foramen, we need to know the jugular foramen, which is very important. 3, 4, 6 cranial nerves are due to the cavernous sinus involvement, and lower cranial nerve palsies are mainly due to the base of skull destruction or due to the parapharyngeal space involvement. 9, 10, 11 cranial nerves. So this is the jugular foramen which transmit 9, 10, 11, and also the jugular bulb. And the hypoglossal canal, this transmit the 12th cranial nerve. Now we are coming to the radiological anatomy of the base of skull. First, I will discuss the pterygopalatine fossa. So this is the pterygopalatine fossa, which gains access, which is to the middle cranial fossa. This is the middle cranial fossa through the foramen rotunda. So there is, if you have a tumor in the pterygopalatine fossa, it can access to middle cranial fossa through the foramen rotunda. So that we need to know. Then it transmits, it communicates with the infratemporal fossa. This is the infratemporal fossa. This is the pterygomaxillary fissure. They gain access or transmit through the pterygomaxillary fissure. Then in the pterygopalatine fossa communicates anteriorly. It extends to the orbit. So this is at a slightly lower cut, superior cut. It transmits with the orbit through the inferior orbital nerve, and nasal cavity. It extends to the nasal cavity through the sphenopalatine foramen. You have the sphenopalatine foramen. So this mainly it is, we need to know infratemporal fossa, the middle cranial fossa, orbit, and the nasal cavity for communications of pterygopalatine fossa. Then you need to know, this is the carotid canal. You can see this is the, I will show you that later. This is the pterygopalatine fossa on this part. This is the carotid. You have the carotid canal here, then the foramen lacerum here. Now we need to know the foramina in a CT scan, how to identify foramina in the CT scan. This is the superior orbital fissure. This is a foramen ovale. Why you need to know foramen ovale? Because it is foramen ovale is more lateral compared to foramen rotunda. Is more lateral because this has to be part of this CTV-P2 in carcinoma nasopharynx, that I will show you tomorrow. Then you have this foramen spinosum. This is foramen spinosum. Very rare to see foramen spinosum in a CT scan. You have the foramen lacerum here. This is the weakest part that I will show. I have told you. This is the carotid canal. This is the jugular foramen. I will show you. I have another slides for jugular foramen. So that this is the carotid canal. This is the foramen lacerum. I am explaining once again. This is the foramen ovale. You have the foramen rotundum that I will show you. And this is the foramen ovale. You have to contour both sides of foramen ovale. This is the foramen lacerum. This is the foramen lacerum on right side. Sorry, foramen spinosum on right side. This is the foramen spinosum on the left side. This is the foramen lacerum. This is on right side. This is left side. This is the foramen ovale on both sides. Now coming to the T4 disease. T4, 20% of the tumors, in tumors, we can diagnose T4 in the clinic itself because 20% of the patients present with cranial nerve palsy. If you have cranial nerve palsies, in second is intracranial extension, involvement of the cranial nerves. Hypopharynx is very rare. In last 15 years of my experience in head and neck, I am yet to see a nasopharyngeal carcinoma with hypopharyngeal involvement because it is rare. Orbit involvement I have seen. I will show you. Parotid gland, because beyond the parapharyngeal space, when a parotid space is involved, then it becomes T4. So this is the parotid. It becomes a T4. The orbit involvement I will show you, that is T4. Then any tumor beyond the lateral border of the lateral pterygoid muscle that have been repeating many times. So this is also T4 disease. The parotid gland involvement is a T4. Now I will show you one by one. This is the pterygopalatine fossa and tumor involving into the infratemporal fossa, extension to the pterygomaxillary fissure, and gaining access to the middle cranial fossa through the foramen rotunda. Can you make out this? An extension into the maxilla. It is also T3 disease. It is not T4. But now coming to the T4 disease. This is a coronal view. You can see this is the cavernous sinus is involved. This is the cavernous sinus involvement. The patient had the lower cranial nerve pulses, 3, 4, 6. Again, this patient had sphenoid sinus, so it is T3, but the patient is having middle cranial fossa, it is T4. This is intracranial extension is present, phenol-sinus involvement is there from a tumor in the nasopharynx. It's a T4. And this is a MRI showing an involvement of the parotid gland. This is a parotid gland. So this is also parotid gland is involved by the tumor, and this is a T4 vessel. Now coming to the intracranial extension through the foramen rotundum. This is a foramen rotundum. Through the foramen rotundum from the pterygopalatine fossa, the tumor is gaining access to the intracranial part. This is a T4 disease. Now coming to this patient, this is one of my patient who received chemoradiation in 2014, coming for yearly follow-up now. This patient presented with proptosis. Can you make out this is a proptosis with 3-4-6 cranial palsies? This is intracranial cavernous as typical cavernous sinus involvement. This closely affecting the brainstem and also involving very closely, if you observe, you can also involving the orbit. This is a T4 disease, and this side, this tumor is this is a very massive tumor. This 2006 patient was in 2006. I think the initial years of my career, and this patient had a pterygoid plate destruction. The prevertebral muscles are involved. The parotid gland is also the deep lobe is involved, lateral to the lateral pterygoid muscle. So due to the parapharyngeal space involvement, it is T2. The prevertebral muscle is T2. Destruction of pterygoid plate is T3. Involvement of the parotid gland and the tumor which spreads beyond the lateral part of the lateral pterygoid is.
Vâng, bài học đến đây đã kết thúc. Cảm ơn các bạn đã theo dõi và lắng nghe. Xin chào và hẹn gặp lại.